In cardiac surgery, there is a moment that seems almost impossible. We deliberately cool the human body to temperature where biological function would normally slow dramatically, and yet the patient survives. So the real question is this: are we truly protecting the organs, or are we simply slowing the moment of injury? And more importantly, what is actually happening inside the body when we do this? Let's understand. To understand hypothermia in cardiac surgery, we need to remove one common misconception. Hypothermia is not a protective shield, it is a controlled reduction in metabolism. It slows biological activity, but it does not stop it. So, in practical terms, we are not preventing injury, we are extending the time before injury occurs. At the cellular level, everything depends on oxygen. Oxygen is used to produce ATP, the energy currency of the cell. When temperature decreases, molecular movement slows, enzyme activity decreases, and biochemical reactions slow down. As a result, oxygen demand falls. But it is important to understand this clearly. Nothing stops to cell remain active, but in a reduced metabolic state. Now we connect this to the cardiopulmonary bypass. As temperature decreases, oxygen consumption decreases. This allows us to reduce pump flow. However, this is where clinical precision becomes critical because flow must always match metabolic demand. If flow is reduced excessively, tissue ischemia can still occur even in cold state. So in perfusion practice, balance is not optional, it is essential. The relationship is explained by a simple physiological principle known as temperature quotient 10. In basic terms, for every 10 degrees Celsius decreases in temperature, metabolism decreases by approximately 50%. This is one of the fundamental physiological bases for the use of hypothermia in cardiac surgery. Now consider the brain. Brain is the most oxygen dependent organ in the body, even at rest. It consumes a large proportion of the total oxygen delivery. So when oxygen supply decreases, it is the first organ to become vulnerable. However, when we reduce temperature, brain metabolism decreases significantly. This creates a temporary protecting window, allowing surgical procedure to be performed safely. But this protection is not absolute, it is time dependent, not permanent. Now the heart responds differently. As temperature decreases, electrical conduction slows, heart rate decreases, and at deeper level of hypothermia, electrical instability may develop. This can lead to arrhythmias, including atrial fibrillation and ventricular fibrillation. So, while hypothermia protects some organs, it simultaneously challenges cardiac stability. Other organ systems respond to predictable way. Lung exchange less carbon dioxide, reducing ventilatory demand. The kidney may increases urine output, a phenomena known as cold diuresis. The liver slows metabolic activity, affecting drug clearance, and blood viscosity increases, reducing microcirculatory efficiency. However, one of the most critical phases is not cooling but warming. As temperature rises, metabolic activity increases rapidly, electrolyte shift occurs, and cardiac excitability increases. This is a phase that requires precise control in order to avoid instability. Another important concept in perfusion injury, when blood flow return after a period of reduced perfusion, we expect recovery, but in some cases, additional injury can occur. This is due to oxidative stress and inflammatory activation at the cellular level. Two key phenomena may be observed: no-reflow, where microcirculation fail despite restored flow, and luxury perfusion, where blood flow exceeds metabolic demand. At its core, hypothermia works by reducing molecular energy. It slows every biochemical process in the body, and that is why it is effective in cardiac surgery. However, the essential truth remains unchanged. Hypothermia does not stop metabolism, it only slows it. The biological clock continues to run at a reduced speed. In cardiopulmonary bypass, we are not simply cooling a patient, we are actively controlling physiology. We regulate temperature, we adjust pump flow, we monitor metabolic and electrolyte balance, and we manage warming with precision, because most complications do not occur during cooling but during transition. Hypothermia remains one of the most powerful tools in cardiac surgery. It increases tolerance in ischemia but slowing metabolism. But it is not protection in itself. It is a controlled time extension. And in perfusion practice, we are not just managing temperature, we are managing the tempo of human physiology. If this video helped you to understand hypothermia better, please subscribe to Circulatory Secrets. I am creating easy to understand lecture to help students, perfusionists, and healthcare professionals learn with confidence. Thank you for watching, and I will see you in the next lecture.